بسم الله الرحمن الرحيم. محاضرتنا اليوم إن شاء الله راح تكون عن الباثولوجي of lymphoreticular system. At first, we have to know what is the lymphoreticular system. The lymphoreticular system is involved in the defense of the body against microorganisms and foreign substances. That's to say the immune response. معناته إنه الليمفورeticular system هو السيستم المسؤول عن الدفاع عن جسم الإنسان ضد الميكروبس اللي احنا أخذناه في محاضرات الاميون باثولوجي. أخذنا الليمفوسايتس وأخذنا الانيت immunity والادابتيف immunity. الآن راح ندرس الهيستولوجي and the histopathology والpathological conditions that affect the areas where these lymphocytes live. Okay? So, what are the lymphoticular system? What are the tissues of the lymphoticular system? It includes the thymus, spleen, lymph nodes, mucosa-associated lymphoid tissue, which is called the mouth in the gut and the upper respiratory tract, and the bone marrow. These five areas they contain the main bulk of our defense mechanism against the microbes. Okay, we will focus of these organs. We will focus only on the lymph nodes and on the pathological conditions that may affect the lymph nodes. So, what are the lymph nodes under normal conditions? The lymph nodes are small in shape and bean-shaped structures. Okay, they are like the bean يعني تشبه حبة الفاصوليا. تكون small. These occurs in peripheral locations and in the deeper locations. Peripheral locations include the cervix, axilla, and the inguinal, and they are يعني rarely to be palpable. Their primary function is they are to entrap the foreign agents or unwanted materials and induce an immune response. So they are like stations where the foreign materials, where the microbes, they enter through the efferent arteriole, efferent lymphatics, okay, and then they will be exposed to the lymphocytes that are present in the cortex and the medulla, and then they will go through the efferent lymphatics after initiating an immune response. So the lymph nodes usually contain cortical area. You can see these are the cortical area, and these cortical area containing the germinal centers. These germinal centers, these are considered as the area of the B lymphocytes. And then we have the paracortex, which include mainly the T lymphocytes. After that, we have the medullary area and medullary cores, and then we have the efferent lymphatics. Okay, of course, we have the capsule that envelop the lymph nodes from outside. So the pathological conditions that affect the lymph node mainly, we call it lymphadenopathy. What we mean by lymphadenopathy? It means lymph node enlargement, and this lymph node enlargement is very important clinical finding. يعني راح يجي المريض اللي يشكي من مشكلة بالليمف نودز راح يجي على شكل lymphadenopathy أو lymph node enlargement. And you have to keep in mind that the causes of lymph node enlargement include two main causes. يعني اما يكون المشكله بالليمف نود هذه نيوبلاستيك زين او تكون رياكتيف انفلاماتوري كونديشنز. يعني اي مريض يجي عنده تضخم بالغدد اللمفاويه نفكر بسببين رئيسيين. يا اما يكون عنده تيومر او نيوبلازم، عنده ورم، او عنده مرض التهاب او reactive lymphadenopathy. For the reactive lymphadenopathy, it either include acute condition or acute infection. We call it acute lymphadenitis, or it may include a chronic inflammation. We call it chronic lymphadenopathy. For the neoplastic condition or tumor, it is either of primary origin, يعني بمعنى إنه الtumor originating from the tissue of the lymph node, we call it the primary, or it could be a secondary tumor involving the lymph node. And why there's secondary tumor? Because the lymph node are considered as a station where the foreign agents are entrapped. Okay, and many tumors or many malignant tumors they can metastasize through the lymphatics and may reach the lymph nodes. Okay, so the differential diagnosis is either reactive or neoplastic. Reactive could be acute or chronic. Neoplastic could be primary tumor or secondary metastasis to the lymph nodes. So we will start with the acute non-specific lymphadenitis. We will start with the reactive condition. This reactive condition, as we said, it is either acute or chronic. Acute, it could be confined to a local group of lymph node draining focal infection, or it may be generalized when there is bacterial or viral infection. So it could be only on a single lymph node, or it could be involving all the lymph nodes of the body. Grossly, the lymph nodes, as you can see here, are swollen, tender, and the overlying skin is red with a fluctuation and could be abscess formation. Yani all the signs of acute inflammation that we study them in acute inflammation are present. We have hotness, redness, tenderness, swelling, and loss of function. Microscopically, there will be large germinal centers. You can see there is the active germinal centers, large germinal centers, and these large germinal centers may contain a neutrophil seen maybe around the follicles and in the sinuses, with the center of the follicles may undergo necrosis, and this will result in formation of abscess formation. يعني the lymph nodes will contain reactive germinal centers, reactive lymphoid follicles, and we may contain area of necrosis and abscess formation because of acute inflammation in the lymph node. We can see here we have the neutrophilic infiltration. This here we have the neutrophil, and here we have the area of necrosis due to abscess formation inside the lymph node. For the chronic lymphadenitis or chronic non-specific lymphadenitis, it could take three forms. We have either follicular hyperplasia, number one, that could occur in inflammatory condition that activating the B lymphocytes. As we said, the follicles are the home of the B lymphocytes. So when we have an inflammatory condition activating the B lymphocytes, these follicles will undergo hyperplasia. And this is mainly seen in some inflammatory conditions like rheumatoid arthritis, toxoplasmosis, early stages of HIV infection. And in follicular hyperplasia, we will have preservation of the lymph node architecture with normal lymphoid tissue between the germinal center. We have variable lymphoid follicles in size and shape. We have mixed population of lymphocytes at different stages of differentiation. And also we have a prominent phagocytic and macromitotic activity in the germinal center. You can see here we have these large germinal centers, and these are considered as some sort of follicular hyperplasia because these are the lymphoid follicles. They undergo hyperplasia with enlargement of the germinal center. You can see there is variation in the size and shape. There's also mixed population. You can see here in higher magnification we have many population of lymphocytes, and we have also macrophages that engulf the nuclear debris. Okay, and this is a form of hyperplasia, or it is a form of chronic lymphadenopathy due to an antigen that activating or stimulating the B lymphocytes that are living inside the lymphoid follicles. The other pattern of chronic lymphadenopathy, we call it paracortical hyperplasia. Okay, why they are paracortical? Because there is reactive changes affecting the T region of the lymph nodes, which are called the paracortical area, as we said. And this paracortical hyperplasia is seen in many viral infection like Epstein-Barr virus, and certain vaccination like smallpox, and immune reaction induced by drugs like phenytoin. Macroscopically, there will be expansion of the paracortical area with immunoblast, hyperplasia of mononuclear phagocytic cells in the lymphatic sinuses, and enlargement of the paracortical area that will result in effacement of the lymph node. So in paracortical hyperplasia, there is expansion of the paracortex, and there will be some macrophages in the lymphatic sinuses, and also this enlargement of the paracortical area will replace the lymphoid follicle. So it will be effaced by the effect of these paracortical enlargement. The last pattern of chronic lymphadenopathy we call sinus histiocytosis. It is characterized by distinction and prominence of the lymphoid sinuses due to marked hypertrophy of the lining endothelial cells and histiocytic infiltration. So these lymphoid sinuses will be expanded by macrophages that infiltrate these sinuses, and also the lining endothelium of these sinuses will undergo hypertrophy because these sinuses they are like the blood vessel. They contain endothelial cells in the lining, and this lining endothelial cells may undergo hypertrophy in cases of sinus histiocytosis in addition to macrophages infiltration. This pattern of chronic lymphadenopathy it is seen in the lymph nodes draining malignant tumors as an immune response to this tumor, or in the lymph node draining an inflammatory lesion. So, if we have a malignant tumor, and these malignant tumors will induce a pattern of chronic lymphadenopathy. We call it sinus cytosis because the lymph node is trying to make an immune response against this malignant tumor. Okay, microscopically there will be expansion of the sinuses, as we see here. There is expansion of the sinuses by by infiltration of macrophages that contain phagocytic debris. Now we will go to another topic, which is the malignant tumors. As we said, we discussed the reactive condition that affect the lymph node. It is either acute lymphadenitis or chronic lymphadenopathy. Okay. The other differential, as we said, for lymph node enlargement is tumors, and these tumors could be primary and secondary. The primary tumors of the lymph node, we call it lymphoma. Okay, lymphoma, it is a primary tumors of the lymph node, and these lymphoma are mainly of two types. We have either Hodgkin lymphoma or Hodgkin disease, which is representing 25% of cases, and non-Hodgkin lymphoma that is represent 75% of cases of lymphoma. So what is Hodgkin disease? Hodgkin disease, it is a primary disease of the lymph node, and it may involve an extranodal site as a secondary manifestation. It has bimodal age incidence. It is seen in the young adults, 15 to 35, and also it is seen in the elderly in the fifth decade. Male affected more than female. The characteristic or the pathognomonic feature of Hodgkin lymphoma is the presence of a certain type of cells. We call it Reed-Sternberg cells. So we can diagnose Hodgkin lymphoma by the presence of a special cell. We call it the Reed-Sternberg cell. So, grossly, in Hodgkin lymphoma, the lymph node will be enlarged and it will become mated and the cross section is homogeneous. يعني الليمف نود راح تكبر وراح تكون متلاصقة مع بعضها معها أيضا cross section مالتها يشبه يعني حتى يشبهوها بالبطاطا يعني بوتيتو لايك فتكون cross section مالها homogeneous whitish to yellowish and the lymph node are mated together. Microscopically, as we said, to diagnose Hodgkin lymphoma, we have to have these type of cells which are called the Reed-Sternberg cells. So what are the Reed-Sternberg cells? The Reed-Sternberg cells are large cells with abundant eosinophilic cytoplasm. You can see it is a large cell in comparison with these lymphocyte and other cells. They are large. They have abundant eosinophilic cytoplasm. The nucleus is binucleated. You have two nuclei, and these two nuclei are mirror image to each other. As you can see, if we have a mirror here, this shape is a mirror image to this shape. Okay, so we have a mirror image pattern between these two nuclei of the classic RH cell. Each nucleus have eosinophilic nucleolus and you have a clear zone around it. Okay, so the RS cells are large cells, eosinophilic cytoplasm, binucleation, and these binucleation are mirror image to each other. They are one like other. They have a prominent eosinophilic nucleolus, clear zone around it. These RS cells are present in a background of inflammatory cells which are non-neoplastic cells. So the neoplastic cells in Hodgkin lymphoma are these RS cells. Now, the WHO classified the Hodgkin lymphoma into many types, and these two main types include either classical Hodgkin and the non-classical Hodgkin, which we call it nodular lymphocyte predominant Hodgkin lymphoma. So we have classical Hodgkin lymphoma or classical type, and we have the non-classical type, which is called the nodular lymphocyte predominant Hodgkin lymphoma. So the classical type include four subtypes, and these four subtypes are called nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depletion. So, what we mean by nodular sclerosis type? The nodular sclerosis type, in this type, the lymph nodes are converted into nodules. From its name, there is nodules, and around these nodules we have fibrosis or sclerosis. So we have nodules of lymph node, and in between we have this fibrosis or sclerosis. So it is the most common form of classical Hodgkin lymphoma. It is the most common subtype, 65% of cases, frequently seen in the mediastinal area, equal male to female incidence, and most of them are young adults. The macroscopically, we have the position of collagen as bands that divide the lymph nodes into circumscribed nodules. In this type of Hodgkin lymphoma, we have lacunar variant of RSL. So we have also RSL, but these RSL, they are a variant of the classical RSL. They are not exactly the same like the previous RSL, like here. This is called the classical RSL. But here we have a variant of RSL يعني الشكل متغير من ال RSL يسموه lacunar variant. ليش يسموه lacunar variant؟ لأنه السيتوبلازم يكون كلير، فكأنه هذه الخلايا قاعدة في لاكوني، يعني تشبه البيضة يعني المقلية اللي فيها يعني فراغ أبيض حواليها، زين، فيسموها lacunar variant of RSL. Mixed cellularity, it is more than 50% presenting in late stage, stage 3 and 4, male more than female, peak in the young adults and again in the elderly older than 55 years. In this variant, we have diagnostic RS, classical RS, and also we have a mononuclear variant of RSL. This is considered as a mononuclear variant, and this is the classical RS. These are eosinophilic cytoplasm, binucleation, mirror image to each other, prominent nucleoli, and a clear zone around them. Okay? And also we have a mononuclear variant, which is considered يعني a variant of RSL, which contain only one nuclei. And in between, why we call mixed cellularity, because we have in the background T lymphocyte, eosinophil, macrophages, plasma cells, and so on. You can see these are the eosinophils and the lymphocyte and other type of cells like plasma and macrophages. In lymphocyte rich, it is an uncommon variant, male more than female, and it is seen mainly in the elderly people. We have in this variant frequent mononuclear and classic RSL, and the background here is different from the mixed cellularity. It is just containing T lymphocyte, and in most cases the lymph node will be diffusely effaced. The last type of classical RS, we call it lymphocyte depletion. It is more common in older male, especially in HIV infected individual, and it is often presenting with advanced disease. Here we have a frequent diagnostic RS, and also we have variants of RSL. Why we call it lymphocyte depletion? Because there is little inflammatory cells in the background. Paucity of background reactive cells. You can see here all these are RS cells. These are the classical RS cell, and in addition to one nuclear variants, these are RS cell. Okay, these are the RS cell, and here we have very few lymphocytes in the background. Now we come to the non-classic RSL, which is called the nodular lymphocyte predominant Hodgkin lymphoma. It is uncommon. It is seen in the younger male with cervical or axillary lymphadenopathy and sometimes with mediastinal involvement. This variant of Hodgkin lymphoma characterized by a variant of RSL. We call it LH variant of RSL, or sometimes we call popcorn variant. Okay, you can see this is again an RSL, but this RSL have a popcorn shape. They are like the يعني تشبه البشار او تشبه البوب زين او تشبه الشاميه اللي نشوفها عاده زين. فاذا هي popcorn variant of RSL in the background of B lymphocyte and follicular dendritic cells. These are the B lymphocyte, okay, and also we have some follicular dendritic cells. So these are the LH variant of RS, called popcorn variant of RS cell. What are the clinical features of Hodgkin lymphoma? This disease is have a bimodal age distribution يعني عادة نشوفها يا أما بالyoung people أو نشوفها بالmiddle to elderly people. عادة تجي lymph node paleness, movable, firm, involving cervical, mediastinal lymph node. Hepatosplenomegaly can be present, and some of the patient may have constitutional symptoms, and these are called B symptoms. اللي تشمل low grade fever, weight loss, sweating, and pruritus. My lab diagnosis, it is not very specific. RBC may have a normal chromocytic anemia, leukocytosis, platelet normal, high ESR. So we need a definitive diagnosis by doing a lymph node biopsy. We have to excise the lymph node and send it to the lab for histopathological examination. How we can stage Hodgkin lymphoma? It is staged by an unarmored staging system that depend on a clinical and pathological staging. So we have four stages of Hodgkin lymphoma. For stage one, there's involvement of a lymph node in a single region on one side of the diaphragm. Then, on one side of the diaphragm involved, we call it stage one. Stage two, there is involvement of the lymph node in two regions, but again in one side of the diaphragm. Then in stage 3, there is involvement of the lymph nodes on both sides of the diaphragm. And stage 4, there is multiple dissemination. إذا staging يعتمد على location where these lymph nodes are enlarged. Stage 1, just we have a single region, and this single region, of course, on one side of the diaphragm. In stage 2, we may have two, three, four regions, but all of these regions are on one side of the diaphragm. يعني أما تكون above the diaphragm بالneck مثلا بالميدياستاينال، أو تكون below the diaphragm مثلا بالinguinal area. فإذا هذا نسميه احنا on one side of the diaphragm اللي هو في stage 2. Stage 3 لا عندنا involvement of multiple regions on both sides of the diaphragm يعني above the diaphragm and below the diaphragm. In stage 4 there is multiple dissemination all over the body. Each stage we may have also a stage A asymptomatic and B. يعني ممكن يكون stage 1A, stage 1B, stage 2A, stage 2B. ال A بمعنى asymptomatic يعني المريض ما عنده أي symptom ما عنده أي أعراض فقط عنده lymph node enlargement. بينما ال B هو معناته having constitutional symptom, malaise, weakness, low grade fever, and so on. Night sweating again. The E, sometimes we have E when there is an extranodal involvement, yani when there is involvement of tissues other than the lymph node, like the liver, spleen, and other tissues. We call it E, stage 1E or stage 2E, يعني extranodal involvement. البروجنوزيس عادة نكون good prognosis لما يكون عندنا stage 1 or stage 2 بالنسبة للهوجكن ليمفوما، بينما بالadvanced stages stage 3 or 4 could reach 50% 5 years survival. Now we come to the last topic in our lecture, which is the non-Hodgkin lymphoma. Non-Hodgkin lymphoma, it is also a malignant neoplasm of the immune system of the body. It is more common than Hodgkin lymphoma. It is seen mainly in the age of 20 to 40. The incidence increase due to increase in the incidence of AIDS or HIV. If you remember, when we take the HIV or AIDS, some of the manifestation and some of the features of AIDS are tumors, and some of these tumor or the most important of these tumor are the lymphoma. So the non-Hodgkin lymphoma may rise because of the increases the incidence of AIDS. Majority arise in the lymph node, and others could be an extranodal origin. يعني the origin of these non-Hodgkin lymphoma, it could be from the lymph node, or sometimes it could arise from tissues other than the lymph node. However, all non-Hodgkin lymphoma could spread to the other lymph node, liver, bone marrow, and spleen. So, what is the etiology and pathogenesis? What are the conditions that may predispose for non-Hodgkin lymphoma? Non-Hodgkin lymphoma it is a clonal proliferation of immune cells, and in 63% they are of B cell origin, 35% of T cell origin, 2% of histiocytic type, and it may have some risk factors or association. The most important association it could be due to viral infection. Okay, Epstein-Barr virus is involved in endemic Burkitt's lymphoma, which is a form of non-Hodgkin lymphoma, and also HTLV1 virus associated with T cell leukemia. Genetic association, some lymphomas having translocation due to mutation of the genes. And also the other association, as we said, the immune deficiency, like HIV or AIDS infection, that may predispose to lymphoma. The other cause is immune suppression due to radiation or drugs, also may be associated with non-Hodgkin lymphoma. The last condition is autoimmune conditions or autoimmune disease like Sjogren's syndrome, SLE, and non-tropical may lead to non-Hodgkin lymphoma. So as we said, yeah, some of the autoimmune disease like Sjogren's syndrome or Hashimoto thyroiditis or SLE, these may have an association with, or some of them may be complicated by the development of non-Hodgkin lymphoma. Clinically, again, there will be an enlarged lymph node, painless asymptomatic enlargement of one or more groups of peripheral lymph nodes. Also, there may have constitutional symptoms like fever, night sweating, weight loss more than 10%. It sometimes may involve not only the lymph nodes but may involve extranodal size like the oropharyngeal involvement in 10% of cases, abdominal involvement like enlargement of the liver, spleen, and abdominal lymph nodes. Again, we may have other organ involvement like skin, CNS, and certain type of non-Hodgkin lymphoma. How we can diagnose non-Hodgkin lymphoma? In addition to clinical and histopathological features, other investigation may help in the diagnosis, which call it hematological and finding. يعني احنا نحتاج الى الكلينيكال هيستوري والاكزامينيشن اضافه الى البايوبسي فايندينج، بناخذ الليمف نود نبعثها الى المختبر لفحص النسيجي لهذه الليمف نود. بالاضافه الى هذا مثل ما قلنا نحتاج الى اذر انفستيجيشن. المريض ممكن يكون عنده انيميا بسبب الكرونيك illness او chronic disease نسميها normochromatocytic anemia. Sometimes we may have pancytopenia يعني decrease in all the elements of the white blood cells and red blood cells and platelets. Features of leukemia in certain patients, we may have some features of leukemia by a large atypical white blood cells and increase in their number. Sometimes we may have bone marrow involvement or bone marrow infiltration by non-Hodgkin lymphoma can be seen in 20% of cases. Hypercalcemia and hyperuricemia may be seen. All these investigations are non-specific, but it could give يعني a hint or could give a clue to the diagnosis of non-Hodgkin lymphoma. So it remains the most important thing to diagnose non-Hodgkin lymphoma is the clinical history examination إضافة إلى histopathological finding after doing the biopsy from the enlarged lymph node. In prognosis, some of these non-Hodgkin lymphoma are low grade that will progress slowly and respond to local radiation in 75% of cases, while high grade lymphoma treated by radio and chemotherapy. So some of these non-Hodgkin lymphoma are low grade, the others are high grade, and we may have many different types and subtypes of non-Hodgkin lymphoma that we will not cover them in our lecture. The last thing, as we said in the lymph node enlargement could be due to metastasis, could be due to secondary tumors originating from other organs and coming to the lymph node and make metastasis. So lymph node we can drain the site of malignant tumor, also may undergo enlargement, and this enlargement, as we said, could be due to sinus histiocytosis, يعني benign reactive hyperplasia as an immune response to these tumors, or it could be due to metastatic deposit, which occurs most commonly in carcinoma and in malignant melanoma. So these represent a lymph node, and you can see in these lymph nodes we have these rounded structures, which are the adenocarcinoma glands. Okay, these are glands of the adenocarcinoma of the colon or lung or other organs. These adenocarcinoma cells infiltrating the lymph node, and this infiltration we call it metastasis, and this metastasis may result in enlargement of the lymph node. Sarcoma, as we said, is rarely to come to the lymph node. They usually metastasize to the blood. These secondary deposits usually involve the subcapsular sinuses initially and later on involve the lymph node trauma. Because the afferent lymphatics enter the lymph node from the peripheral area, so these glands will enter in the periphery at first, and they, with the time, they go and go inside the tissue of the lymph node. So I finish my lecture today. Thank you for your listening.